So now it's time for a friend from Szeged, which is a town in southern Hungary, 200 kilometers south of Budapest, where Istvan Nemeth works as a pathologist, and I think you're a surgeon as well. And he will tell us a little bit about melanoma research in Szeged.
Dear audience, first of all, I want to thank you, Johan and George, to be here. And I can just join to Chris. This is a very unique conference, and the unique thing is because of you sitting here. Patients, relatives, scientists, doctors, clinicians. It's a very new multimodal aspect, so it's a great honor to be here. So I'm coming from Szeged. It's situated south at 200 kilometers from Budapest, and it's situated a great plain of Hungary, and it has a very unique fashion. And I'm telling it to Patrick, it's completely flat. So no even 1 meter up, 1 meter down. It's very flat. So across 300 kilometers, just you can go by bike without any expertise. So this is a Szeged here, and I'm originated from clinical center, dermatology clinic, head by Professor Lajos Kemény. We have a mixture of things like we have an outpatient clinic having 2 new melanoma cases per year, and we have a comparable area to this area, so approximately 1.5 million inhabitants. We have a plastic surgery ward, we have a dermatopathology unit having 5,000 surgical cases per year, we have a dermato-oncology, and of course we have an onco team for our patients. So we have heard about success story today about melanoma. So what does melanoma mean? Not much good. So when you tell the diagnosis to the patient, it's a bad feeling because it's a tumor of the melanocytes and it's a malignant tumor. The malignancy means that it has a capacity to give metastasis. And melanoma is one of the most aggressive cancer, very aggressive cancer. I would like to ask your favor. I need 2 fingers. All of you, just hang up, just 2 fingers, and try to measure 2 millimeters. Okay, try to cross, or okay, you got it? Okay, now try to make a 4 millimeter distance. Is a big difference? What do you think? Big difference? It's not a big difference, but it is a very big difference for the patients because the stage of melanoma depends on the thickness of the tumor. It's not measured by centimeters as other tumors, millimeters. So in 2002, patients having 2 millimeter thickness of melanoma, the survival of 70% for 10 years. So 1/3 of patients died because of 2 millimeter melanoma. And if you check the 4 millimeters, half of patients die because of 4 millimeter thickness melanoma. So it counts a lot. It was in 2002. And now what's about 2017? That's from the latest WHO classification and AGCC 8 edition, and you see in certain group having a thick, 4 millimeter melanoma with regional lymph node metastasis, having a chance to survive 10 years, 20%. So it's very sad. It's very sad. So it's a big challenge for us. So as we have heard, there is a national course of melanoma. You have many moles. I'm pretty sure everyone has moles. It transformed to a malignant, so you can get the primary melanoma. And these cells can be detached. It's called cellular discohesion, can spread either via lymph, forming lymph node metastases, or distant metastasis, like brain metastasis. The melanoma likes the brain, like seed and soil, because the melanoma is a neuroectodermal tumor. So it likes the cousin, and that's the brain. And that's usually fatal. So patient, doctor, melanoma meeting. In optimal way, as a dermatologist, I meet the patient at the stage of mole. Okay, it's just a routine mole check. Okay, let's check the moles. Okay, I'm doing dermoscopy and I can choose a suspicious lesion for melanoma. and send the patient to the surgeon. It's cut up, sent to the pathology, histology. The histology tells us whether it's benign, malignant, whether the resection margin is free or not. And if the melanoma diagnosis is proven, of course, it's a line on dermato-oncology and onco team. And if the patient has a metastatic disease, of course, she or he can also meet these modalities. My luck is that I graduated as a pathologist, so I'm doing dermatopathology and routine pathology, but I also graduated as a dermatologist. So I'm doing dermatology, dermatopathology, and in our course in Hungary, we are allowed and we must do dermatosurgery. So actually, I'm checking the patient for suspicious lesions. I can operate, I can check the slides, and of course, I can follow the treatment of the patient. So it's important. It's an interesting journey for me to follow the patient, and the patient is good because he can follow one doctor. Of course, always if you have some discussion, of course, you should be based on team assignment, so it's not just unique and not just one doctor assignment. So dermatologists using dermoscopy. So here we have a suspicious mole. The local excision, usually if it's suspicious, we make a 5 millimeter distance. So it's like a bay leaf surgical excision. It's a local anesthetic procedure. It's fast, quick, so it's easy to do it. After sectioning is important by pathologists, we embed it into paraffin. It's a hard material, easy to cut. And after that, we get, we get 2 4 micrometer thick or thin slides, either for routine or for ancillary techniques like immunohistochemistry. Now the pathology is not just based on phenotype. You can use immune stainings, so especially double stainings. So for example, let's see these cells. These look like the same, like fasciculars. But by immunohistochemistry, by protein analysis, we can stain different proteins. We can distinguish the brown label melanoma cells from normal red label fibroblasts. So we can divide the bad cells and the good cells based on the histo. Like, as you see, like the supporters in a football match, it's the same. Without the color, they look the same. So I would like to show you daily routine cases, my cases. Case 1 is a lady aged 34. She's a lawyer. She just came to me because of the regular mole check. Here you see the moles, and I found something suspicious. Here you see the dermoscopic picture. The periphery looked like a mole, it's benign, but the center, something suspicious. So I cut it, and here you see the picture. This is the epidermis, this is the upper layer of the skin, this is the connective tissue. Normally, the nevus cells here and here, located at the junction here. So that's the normal nevus, as you see here at the periphery. So these are normal cells, normal benign, benign cells. But these scatter cells, we have heard about it, the detachment, the spreading. So these, the cancer babies, which already detached, but thanks God, these are within the epidermis, so they couldn't find a vessel. So it's early stage melanoma. So I cut it up, I follow her, and she's okay now. She has a baby aged, now she has a baby. Case 2. It's a lady aged 37. She's working in a nursery school. In abdomen, I see the same, suspicious mole. And here you see now the same. At the periphery, you see the normal melanocytes, okay? And now you can find the bad cells. Where are the bad cells? And on the up, alone. So these are the detached cells. This is an early stage melanoma. She's also okay. I may follow up, and everything is fine. The third case, it's a man aged 40, and actually she came to me because of genital infection. So no problem with the moles. And I asked, "What's about your moles?" And he told me, "Oh, 6 months, it was checked. Everything is fine." Okay, let's do it for sure. Let's do the mole checking. And I find suspicious. And when I showed him this, he thought that, yeah, it's changed. Last 3 months it's changed. The center is got whitish discoloration. And this is the cross section. So here you see the melanoma again. You see the up cells here. And this is called regression. You see these spots there? These are immune cells. The immune cells attacking the tumor, and here there is a vanishing of the tumor. It's called regression. So clinical picture from cellular level, you can match it. It's very, very interesting, very fascinating. So this is regressive melanoma. I follow him. He's okay, but of course, careful follow-up should be making. This is a very interesting case. This is a gypsy family. I replaced someone in the pediatric dermatology ward. What do you think? What is the difference, for example, between the mother and the children? Yeah. Maybe the picture is not. It's a gypsy family. Exactly. First, the mother came to me just to gain some certificate to the daughter for the school. And behind, I saw Kalman, is the son. Kalman, how are you? And I start discussion, okay, whether these are relatives or something. And he's the real son of her. So I knew that white color, of course, predisposing to get melanoma. So I checked Kalman and I found a thick melanoma on the back. The excision at age 10 years old man is not local anesthetic excision is not easy. So it needs a high compliance. So 10 years old boy, but I solved it with a big car toy. That was the present, and it was successful. Now we follow up of him. He's still okay, so we hope sustaining. So there are also non-natural causes of melanoma. Let's check this patient, age 20, in 2002. It was a primary melanoma, and it was an early stage melanoma. The thickness was 0.5 millimeter. So you cannot even measure what's about 0.5 millimeter. Okay, excised, everything is fine, follow up, good prognosis, and after, you see, 4 years, he got lymph node metastasis and a distant brain metastasis. This picture is from her. There is a metastatic. So it was 4 years free of disease, and after she got a manifested disease. So it's very interesting. Long time. And there is another case. It's a lady aged 75 with advanced melanoma. You would wait, it's advanced melanoma, thick melanoma, should metastasize, should be fast. Nothing. For 10 years, nothing happened. And after 10 years, he got the recurrence and got a surgery, a new recurrence. So the gas pedal was pushed. What it means, what it tells us, that it might be an early dissemination of latent tumor cells. So these patients latently in advanced disease. So it's not a question whether you have a metastatic cells or not. Yes, in certain cases. The question is how they can manifest the tumor. So that what are the regulation of a late metastasis formation? So it's a good question, should be answered. So what drives the melanoma in its evolution? It's like a small evolution within you. It's a small evolution, like we are doing in the world. There are drivers. And now it's found the molecular steps, how the benign lesion can lead to intermediate, malignant, and spread. So there are molecular steps, and in case of melanoma, it's mainly driven by UV. There are high UV melanomas and low UV melanomas, but the UV is very important. We have heard today, Lund now is a town of sunshine. Szeged also is a town of sunshine. So there are gas pedals of the tumor. And one gas pedal we heard about today is a BRAF. It's one gas pedal. Push the gas pedal. And this is a cooperative work with George, and many thanks for him, everything. And this is a protein staining. So what it tells you that the brown discoloration means the expression of this mutated protein. So actually it tells you these cells which are brown already push the gas pedal. But just to push one gas pedal is not enough for a tumor. You have to lose the brake. So it's very important. The cell cycle regulation is also important for that. You should lose the brake. The problem is that the melanoma has too many gas pedals. So if you stop one, like BRAF inhibitors, one gas pedal, it has another gas pedal, and it's a big advantage. And I think the proteomic will tell us more complex story about that. So you might think the cancer may be a systemic biological disease, not just confined a mole. It's more, but unfortunately latent. So we don't see it. So we have a latent disease phase. It's like an iceberg. And the clinically apparent disease, like a tip of the iceberg. We have a minimal residual disease, and of course, again, we have a metastasis. So the crucial point from the primary tumor, or from the blood, how we can predict the personal behavior of each tumor. Because what's the importance in pathology? What the clinician ask me, I'm asked myself as a clinician to pathologists as myself, what the patients ask me, what's about my prognosis? What's about my tumor behavior? So in order to solve this problem, we need data. And now I want to follow the next presentation line. We need big data. It's very important. But take care. It's not like a teenager sex. Like, as Dan Eiley said, big data is like a teenager sex. Everybody talks about it. Nobody really knows how to do it. Everyone thinks everyone else is doing it. So everyone claims they are doing it. But it's important to get how to know the cancer, how to know for our patient benefit. Very important to have a very good tumor bank as existing here. And the reason why I'm here, not just to release you presentation, that you study Szeged, to study how György and how these tumor banks doing the things, because we need to study much from here. We have a multimodal approach, as we heard from the lectures. We have to ask very proper questions, good questions with good answers. And it's very important for comparison, the relevance, these data, this meaning, whether it's beneficial for our patients or not. It's very important because that's the main aim, the relevance for our patients, for you. So, behalf of my head, Professor Kemény, and the onco team consisting of dermatologists, pathologists, surgeon, plastic surgeon, ENT specialists, radiologists, and psychologists, let's release the very big welcome and very, very big push forward to this meeting. And really thank you to be here, and thank you everything.
David Fenyö, who comes from the Department of Biochemistry and Molecular Pharmacology and works at the Institute of Systems Genetics.
Thank you. Thanks. Yes, thank you very much. So I'm going to talk about big data, and specifically big molecular data. And I'll go into a little bit more detail about... so when Juri first asked me to give a talk, he said, do a popular science talk to a wide audience. And I figured the best way to do it is to actually show data and go into details, because everyone loves data, of course. So you've seen this already twice today. So this gives an overview of different hallmarks of cancer. But the one thing I wanted to point out is that it usually... It starts with the genome instability. So that's how we get cancer cells, by the genome changing. But the actual, to overcome these different hallmarks, to actually become a cancer cell, we do need to produce proteins, and it's the proteins that are the functional gene products that actually makes the cells different. You've seen a similar slide earlier from Tom Conrad's. So the kind of data that we are talking about here is we can measure the DNA. We can actually resequence the whole genome of patients. And there are now tens of thousands of genomes available of patients. So from here we can look at if there are individual mutations, but also if there are changes in copy number of larger regions that can change things. Then we can measure RNA very efficiently. And then you've heard several talks about how we can measure proteins and their modifications also. So this is very easy to measure, DNA and RNA, and proteins are much harder to measure. But the problem is that if we go with just measuring RNA, for example, we can use that sort of as a surrogate of measuring proteins, but it's not always such a good idea, and I'm going to show you that. We really need to do the measurements here. So this is, of course, a very simplified picture, and you'll see some evidence why that is. There is a lot of other regulation going on here and degradation, and so it's remember that it's a simple picture. So now let's look at some data. So now we can measure tens of thousands of genes for many tumors, but now we're just going to look at one gene. So first we're going to look at the relationship, what happens in transcription. So now here we have how many copies of this gene we have in the genome, and then how much RNA there is. So the step of this transcription when we copy the DNA into RNA. So what we can see here, so this is for breast cancer, and what we see is that most of these tumor samples, they're somewhere here in the middle, so not much change to the DNA, but there is a group here that has more copies of this gene. That's called RBB2. This now, what we see also is if we have more copies of the gene, we have also higher amounts of RNA. And then if we go down to the next step in the central dogma, the translation, so going from RNA to protein, we see again that there is a correlation, quite a strong correlation between the amount of RNA and the amount of protein. And then finally, if we look at modifications, so this is looking at one phosphorylation, we see that we have an even stronger correlation between the amount of the unmodified protein and this phosphorylation site. So now this is for breast cancer. So now this is the case where we have very good correlation between the different molecules in the central dogma. But then if we look at the same gene in ovarian cancer, we see a completely different picture. First of all, there's almost no change in copy number or RNA levels, but there's still quite a big range of protein amounts, roughly the same as for breast cancer. But there is no correlation between phosphorylation and protein. So if we go look at different genes in our data, we see any type of patterns you can imagine. So sometimes they're correlated, sometimes they're not correlated, and sometimes even anti-correlated. So the other thing to say about ERBB2, so this is known to be amplified in a subtype of breast cancers, and there is actually a treatment or several different treatments for this subtype. But that treatment is only used in breast cancer and not, for example, in ovarian cancer. And we can see why that it has a completely different mechanism. So it's very interesting. So we're talking about collecting big data, but what I want to point out with this is that we should actually go back and look at the details of interesting, look for interesting patterns, and actually just manually look at things. Even though we have algorithms to extract interesting genes, it's very important to go back and look at it. And it's actually easy to forget that. So now another thing that we can look at is correlations between different molecules. So now again we have ERBB2 and another gene that's called GRB7. So here we see that on the DNA level, when there is a copy number change in ERBB2, there is also a copy number change in GRB7. So it ends up that they are close to each other on the genome. So that's not so surprising. But then we also have a correlation, high correlation RNA and protein level. But if we look at another pair of genes, again ERBB2, but now ERBB4, we don't have copy number changes in ERBB4. There's no correlation on the RNA level, but we see high correlation on the protein level. And in this case, that's because ERBB2 and ERBB4 function together in a complex, so they are then correlated on the protein level. So these were just some to give you a little bit of a flavor of what, in the context of the central dogma, when we actually do measurements on tumors, what we see. So now I'm going to focus on just one small project that we worked on, is to focus on the kinases. So these are proteins that phosphorylate proteins. So why kinases are interesting is that there are actually a lot of kinase inhibitor drugs that are approved, that are actually on the market, and physicians could give them to patients. But in most cases, one doesn't know when to use these drugs. So what we did is we looked at a collection of measurements from breast tumors, and what we did outlier analysis. So it's a very simple analysis. You just look at which in a specific tumor is this gene very different from the whole population. So just looking for anomalies. So what we then see is in this example here. So again, if we look at our favorite gene, ERBB2, we see that we have in this one subtype of breast cancer, we have the amplification, the change in copy number. We have outliers in the transcript, the proteins, and the phosphopeptides. And then we have other genes that show either the CDK12 shows similar pattern in similar samples, but then we have another gene, PAC1, for example, that shows the same thing but for other tumors. Then we also see a lot that are only outliers on the phosphopeptide level. And that actually turns out to be very interesting, and we used that in a small pilot study where we had 6 tumors from 6 different patients. Then these tumors were put into mice to make these patient-derived xenografts so that we can do treatment experiments on these tumors. So the interest of it was testing one drug that is called BKM120, but it's not so. But that what turned out is that 2 of these tumors were very sensitive to this drug, so you could treat it well. But 2 were not were resistant, and then 2 somewhere in the middle. But the idea was that I mean all these 6 tumors were otherwise classified in the same basal subtype. But then, so we did, for each of these, we did different treatments, one very short treatment, and then longer treatment, and we had control treatments also. But what we did is then to measure the transcriptome and proteome and phosphoproteome both before and after treatment. And the question we wanted to answer is why do these tumors differ in their sensitivity to the drug? And then again here we use this outlier analysis to do this. So we found some outliers on the phosphopeptide level. So here we have the highly resistant tumors. And then we found a group of outliers that were mainly observed in the resistant tumors. And they turned out to be, then we picked 2 of these so they're called NEC9 and MAP2K4. And they seem to be 2 examples that played a role in this resistance. Then we had a cell line that we knocked these down. And then this cell line was then resistant to the drug, and then by knocking each of these down, it became sensitive. Just to summarize, so I've talked about, so all the results I've shown have been from this outlier analysis. So why is this outlier analysis so effective? It's you talk to any statistician is going to tell you that that's really ridiculously simple method, and it's not beneath most people to even try such a simple method. But what turns out is that this data, when we measure these big data sets, molecular data sets, the problem that we have is that there's a big biological variability. We have so the data is noisy because of that. So a simple method is often works much better than more complicated methods. And the nice thing, it allows for actionable things. So we can imagine that in the future, when the primary tumor is taken out, we do this analysis, we look for the outlier kinases, and then design a kinase inhibitor cocktail to be given specifically for this patient. So thank you very much. And this was within the CPTAC consortium, so a lot of people were involved. Thank you.
Thank you very much, David. Now it's time for Garry Corthals, who is, I found it says professor of supramolecular separations. Is that true? Supramolecular
But that's what it says on the
separation.
website. I just don't know what it means.
No, neither do I.
I invited Georgie to my wedding. He knows what I think of communities and how communities operate. For those people that have been here and told their story, you're clearly on our radar. Thank you so much for sending out that signal today. Again, the bleep, keep on doing it if you can. We see you, we hear you. We really, really want to help. I was told to give instructions like others, and I'm not going to give a scientific talk. I work at the University of Amsterdam and Maastricht in the hospital there as well. I'm going to tell you a story about proteomics and how would we tell this story and what are we going to do in telling this story and what are the steps involved and why I think it's important. But what I want to start with is just some context. So it's been 15 years since the human genome was made available to the public, and we know that. And that launched, interestingly, a whole cottage industry of companies that would tell you how specific your genome was differently to some other genome. Because what you want to know is what drug works for me. And we've heard things like personalized medicine. And there are other terms, epigenetics, you know, what the proteins and modifications do on top of genomes and how that influences us. But there's a lot of science talk and a lot of industry. And I think what we've seen as well is that it's a model, it's an extremely expensive model, and we can't do this alone. So we're living with the notion now that we have to share and pool our resources. And a lot of speakers have talked about how they're working with this organization. And I can only see that as a good thing, and it's our obvious future that we have to do. And so the idea here is that the information is important, but you don't need to own it. You just need to know what it means. I want to talk about information today, and I'm sure that many of you, for our scientific language, you have no clue what we're talking about. I've been doing this for a really long time. If I don't pay attention with one of those slides, I'm lost. I'm a professor in this stuff. I'm lost. So it's not simple. Something that has happened also, and I think Alan Edwards is for me someone we have to invite to these meetings. He's championed the notion and idea of open science. And open science is making available what we discover to the general public. We have to do that. It's really important. We don't need to own it. We need to make it publicly available and humanly interpretable. That's happened with a lot of genomic studies, but we haven't seen this yet at the protein level, the work that we do. And why not? I don't have an answer. I don't have answers for the questions that I'm always going to ask. But what we do know is that every drug acts on a protein and influences your state at the molecular level. So it's clear that we need to have knowledge at the protein level. That's what we're talking about today, a lot of the work at the protein level in patients. So let's put that in the public domain. Something else, it isn't in the public domain at the moment, and so I don't want to use the term that we hoard data or we keep it from you. But we just don't have a mechanism to make it public at the moment. Giving you access to a database, taking away the patient registration numbers, is not public domain. It needs to be humanly interpretable, explained what the question was, explained how we can access the data. I have to tell you, this is my interpretation. When I look at this data, these are my conclusions. Then you need to be able to look at exactly the same data and say, well, I've looked at this differently, and if I look at your data and their data, now that's something different, because have you seen this? And that way we can do things differently. And when I say make it publicly accessible, I mean patients. I mean healthcare providers. It's got to be at that level. It's got to be at that level, because I will get there in a minute, but where I finished last time was that I don't think we have a sustainable model the way that the pharma works at the moment. Anywhere between $1 billion to $10 billion it costs for a new drug. It just, and we have something called like Eroom's law, but essentially we see that the pharma decline, that model will just not work in the future. So we just can't make drugs the way we've been doing it in the past. So the point there is that we need more open studies and open trials for patients than industry trials. Because if they don't work, and Georgia, you can probably attest to this one, if they don't work, that information does not go to the public. it's kept as an industry secret. There are financial issues. Public and open trials, information does go to the public. So let's move on from just having scientists look at the data. And I've somehow in my career, I don't know how this started, but I've always been involved in communities. EUPA is a European organization. We now have 20, do you even know, 20, 25 countries, thousands of members, and just with little ideas. This is a little idea about the story of proteomics. What is it? Who's going to tell it? These are good questions. Last time I finished here. Last time I was in Lund, I finished with some questions. We're generating information about patients and patient tissues that are overwhelming to many. And I'm talking about scientists. We don't have a community that can take the information and apply this to patients or research models. It's clear that we need to work with patients. Test tubes, that's not working. Animal models, they're not working. Patient models, clinical trials, 90% works. The challenge is not in generating the information, but helping clinicians and researchers and the general public understand it in the context of their disease and in all of the various forms of cancer we've seen today. It can't be more important. Personalized medicine at a level where you can look at exactly the same data as me, because it is ultimately something that's pretty close to an Excel table with a protein, and this has gone up or down in its level, in its concentration. And how can we picture that together? Which drug pathways do I respond to? These are not difficult questions. So, continuous education we need, the top point. Humanly interpretable information to scientists, clinicians, patients, the public. And that impact we want to have quickly. So what's our story going to be as proteomics? I can tell you one thing, that we're working on the story, but you do not want a scientist to tell you how this is going to work. You've heard this today. We're hopeless, right? The real scientific talks, because you don't understand them. So I know this because I've now been involved with a company who's asked me several different times, tell me exactly what it is that you're going to tell this story of proteomics. And it's difficult. It's very difficult to just get simple information across. So proteomics is complex. So we need to design thinking methods, co-creation with other groups, and I think visualization. It's pretty clear what visualization is, right? On the left, we have a couple of balls and languages. You can guess that I'm trying to say stuff in different languages. It works. Imagine if I had that as a bullet point. That's horrible. So the visual process and results make it easy to have simplified and efficient communication with stakeholders. So that's what we've been doing in creating the story. We've gone and started to work with a company called Jam Visual. Gopras I'll explain later on. But the effects of the visual way of working are these 3 points here. We see the connections, we recognize and visualize the relevance, and from that, people start asking questions. So new concepts, new ideas, creative solutions. So we started to scope, so establish what the story would be, a visual story for proteomics. Define the objectives for the story of proteomics, and the important goals of the story were to, as we've put it now, create awareness. And there will be, you'll see later on the page with cancer-related, the awareness, the education, and get the community involved. They're the 3 outlines that we have at the moment. So the strategy so far has been that every member gives his or her vision, so these images are taken as we were doing it. Who are the senders? Who are the receivers? Some people do both. In hospitals, you send and you receive information. At a university research group, we send information quite a lot. Stakeholder and patient groups receive information. But I'd like to see those lines more blurred. And there will be an outcome and a desired outcome. And so what we have, and I don't know if you can even see this, but from these boxes and from the scoping in the first draft is, why now? Protein, what is that? It's an alternative. Do you need to know more? It's an alternative. It's pretty clear that knowledge of DNA alone is not working. So let's explain it. What is the state of the research in humanly interpretable language? Value for society, value for the patient, value for the families. Who are the groups to get involved with? And a call for action, and a community that can embrace that and pick up on it. So in phase 1, that image is awesome. The whole thing was about visual. The only thing that I can't do is give you an image. So we have this phase 1. We build the visual story and work on the story design. And so we've gone through this analysis and the visual concept and the story design. In the second phase, we'll have this validation. And at the moment, and I'm putting the money here as well because I'd like you to know that there are no research grants that you have for this. So what we've done is just write to charitable organizations and they respond. They say, hey, but this is a good idea. This is interesting. So this phase 1, we're ready, and we're in the completion of this process right now. And phase 2, we work, this is the term from this company, we want to go from a static image. So I've talked about the images. We've looked at a number of different ways of getting the story across, and the first one was a MOOC, which is a open online course. I think massive open online course. Universities work with them quite a lot, and so does our university. And this is being recorded, right? I wasn't too impressed. That's except for my colleagues, they were great. And what I wanted to say is, well, then I looked at other ways and was on my mind for a long time, and then finally came across if we can actually just tell the story through images. And so what we're going to have is something like this. And I want you to look at this, and this is in Dutch, unfortunately, but we have medicines in water. And it's an image. And I think you can see it. Number 1, we have, in Dutch then, we have care, water, the government. And we have in this big pool, which is in a polder in Holland, we have the medicines flowing into it, number 2. Number 3, we analyze it. And 4, what are the regulations? 5, what we have is the industry with the doctors and the hospitals and the apotheek, chemist. 4, 5, 6, 7, we have this guy peeing in, and that's it's a very clear circle. Who is involved? What are the stakeholders? What's our story going to be with proteomics? I don't have the image for you, but let me show you this, because we have defined this already. Is this still here? Yes. We will have a version with a tagline for this is 2020. We will have it in at least 20 different countries and 20 different languages. And so here we have an English version and a Dutch version. There's a web dossier and an intro video. But the point is that we want something simple that people can look at. If we click on one of these, we have a next level of information. And then a next level of information. And if you're really keen, you can go to a long read. This is essentially the setup that we will have with the website. And the important part is what is related. Who is, because of the localization, is what are the local groups doing? Who are the stakeholder groups? And the area of cancer, of course, is going to be covered here as well. But how do I get involved? I'll go back to the presentation, I thought. Ooh. Yeah, that was easier said than done, wasn't it? Yeah. So what we will have is an interactive presentation, the animated intro version, visualizations, and a zoom level and localization in your language. And there are some costs involved. And I put the costs here because I wanted you to see, because I think we have an objective to reach 10,000 people. We've set that as an objective. So, how are we going to do that? And we're working on a strategy now. So here are our goals. So what will our story do? Create awareness, educate, get a larger community involved. So how are we going to do this? So we're pretty excited about the crowdfunding campaign. And you might think, oh, another one of those, and they can get lots of money. You're not allowed to donate a lot of money. The point of the crowdfunding is that many people know what it is. So you can 1 or 2 euros, we're more than happy. But tell someone else. That's the main thing. Tell someone else. Because then we will start to get people to understand at a pretty simple level, is it really that important, this protein work? Why should we be doing this? That's the main thing. From this crowdfunding, we move to our next stage of funding, and then we will finish the project. We will not accept large funding from industry either, and that has already been asked because we could get it done with 3 companies. We will never reach the awareness that we have as an ambition if we get 2 or 3 companies to fund it, because they will tell a few people, and that's it. It dies. If everyone contributes to helping us make the story, everyone will know the story. We have in Amsterdam and perhaps in is it Manchester or Sale? We have a school maybe. In Amsterdam, what we have, and in Rotterdam we have, is a group of the same age as you, probably 16-year-olds. They're going to make their videos, and that's a worldwide challenge for what is your story of proteomics, and they get to tell it in a minute. I have one more thing to say. And the other one is that there's a next campaign that will become, you may have heard of something called Be My Eyes. There is also what we're going to launch is Be My Scientist. Are there local scientists that can help me interpret this data or read something about a paper? And you can be on a list in Lund or in Rotterdam or in Amsterdam. So they're the ambitions of what we want to do. We have the school children, and the pathology scoring game is also on the cards. That's what I wanted to talk to you about today. And I'll just finish with this to thank my employer, Amsterdam, HUPO. I'm the chair of HUPO Education, this organization, and GAPRAS was a project that kicked this all off for me. And we have the visualization through Jam Visual. Thank you.
Thank you very much, Garry, Professor of Supramolecular Separations. Very fine title. Now, here we have a thoracic surgeon instead, Theresa Stork from from Vienna. Please.
Well, it's a huge honor to be here. I am not quite a thoracic surgeon yet. I'm a resident and just started my PhD in collaboration with Lund, and I was asked to talk a little bit about what we do in our department. Do you have this? I can do it like this as well, it's fine. So, it's fine, I can use the computer. So this is basically our department. There. So it's fine. So what do? We do, of course, surgery. About 420 lung resections each year, mostly for cancer. We do EPPs for mesothelioma, and about 60 surgery for lung metastasis, mostly from colon cancer, melanoma, or sarcoma. We do some esophageal surgery and some other surgery not related to cancer, about 110 lung transplantations, but that's not what's interesting now. Our clinical and research focus is on thymic malignancies, lung metastasis, and the research group I'm working at focuses on pleural mesothelioma. So I was thinking about what should I tell you about surgery. It's a very broad topic, so I thought I'd just bring 2 cases that I thought were pretty interesting. So the first case is about a female patient, 56 years old, smoker, COPD, and she was admitted to the hospital due to exacerbation of the COPD. Then CT scan was performed, and you can see here on the right side a pretty large mass in her lung. Then PET CT scan was performed, which showed the quite locally advanced tumor stage T4 and 2. with no distant metastasis. And she then had further workup. A lung function test was done with a forced expiratory volume of 1.17 liters, which probably doesn't mean much to you, but this is means that this is only 44% of her normal volume, so that's not a lot. And actually also very bad blood gases, which means the oxygenation in her lung was not working properly. And bronchoscopy was then performed to get an histology, and that revealed that she had a squamous cell cancer of her lung. She was then discussed in the tumor board, obviously, and it was decided at that time that she would not be a candidate for an operation and also not for radiotherapy, but we would rather go for chemotherapy instead. So she received 3 cycles of chemo, and then this restaging CT was performed, where you can see here that actually the tumor did not regress but was growing further, reaching the carina and almost completely blocking her right lung. This also showed that she developed progredium symptoms with dyspnea, needed 4 liters of oxygen during the night. And now we were wondering what to do with her. Do we put the stents? Do we do radiotherapy to relieve her symptoms? However, then my boss came, who did not know the patient before, and said, well, no, I'm going to operate. This was discussed quite a lot with the patient and with her treating oncologist. And what was then performed was a rather large operation called sleeve pneumonectomy, meaning that one side of her lungs was removed, and also the carina, where usually the trachea divides onto both sides, and then the both lungs. So the left lung, the left remaining lung, needed to be reattached to the trachea. You would think that with her bad condition before the operation, she would not survive this kind of operation. However, patient was doing excellent. She had no dyspnea after the operation, that did not need oxygen anymore, and was then discharged on the 5th postoperative day. This was most likely due to the reason that before the operation, she had shunting in her pulmonary shunting, meaning that there was blood coming through her right lung, but no oxygen anymore. So all the blood coming through to the lung was not oxygenated, but was coming to her body. And when we removed this lung, all the blood is now in her remaining lung and could be oxygenated properly. So this was normal X-ray after the operation. You see the one side is filling with fluid. This is completely normal and happens every time after pneumonectomy. And the histology revealed the squamous cell cancer we knew before, PT4N1M0, so stage 3A. And then the decision was made to give her adjuvant chemotherapy. However, after 3 cycles, at the restaging CT, there was this lesion found where we had the suspicion for local recurrence in the lymph nodes. And then after 1 more cycle of chemotherapy, she had endobronchial biopsy of this lymph node, which luckily revealed no malignancy. And the patient is still doing fine and without any signs of recurrence. And what is very important is that we could also give her quite a good quality of life, and she's less symptomatic than before the operation. The second case is a very young patient, 33-year-old female kindergarten teacher. She was in a perfect condition, basically, physically active, ECOG 0, Kanofsky 100%. She did never smoke, had no history of any exposure to asbestos or any other. And then she developed recurrent pleural effusions on the left side with completely unclear etiology. At first, she had no sign of any infections. So this is the CT scan. You can see that the left side is totally shadowed by the effusion. What you can also see is that, can I point with this? Yeah. that she has here some lesions on the inside of her chest. They showed also PET positivity in the PET scan. There were recurrent turcosynthesis performed, which only showed chronic inflammation and no growth of any bacteria or fungi. TBC was also negative. She then had further workup regarding her heart, which basically was fine, but there was only seen the significant pleural effusion. Spirometry was actually quite good when you think about that one of her lungs was not working because of the fluid inside her chest. So, of course, we needed to do something and then decided to perform VATS surgery, so video thoracoscopic biopsy. And the frozen section revealed malignancy of unclear etiology. We then put talcum inside the chest, as you do, to fuse the lung to the chest wall so there cannot be any fluid anymore, to relieve her of the symptoms. This is not a treatment. The final histology very sadly revealed epithelioid pleural mesothelioma, which is a very aggressive tumor. So this was actually the situs inside the chest of this patient I'm talking about, where you can see the huge tumor masses. So this is all tumor inside her chest, and those are the lungs with also small tumor masses on them. But it was still a T2 tumor, which is locally advanced, but still resectable. She was then discussed in the tumor board, and the decision was made to do the maximal therapy available, which is a trimodal therapy. And in this case, we did neoadjuvant chemotherapy first, then maximal surgery, EPP, meaning extrapleural pneumonectomy, and then afterwards followed by radiotherapy. And what we also do, or in her case, or in all our mesothelioma cases, is we put H2O2 inside the chest during the operation, when the lungs are already out. So she went for the chemotherapy. It's standard chemotherapy with cisplatin and pemetrexed, which was very well tolerated by her with no significant side effects. Then she went for the restaging, which actually showed a pretty good response. So then we went for the operation. She received this extrapleural pneumonectomy, which means that we take out the whole lung and also the pericardium and the diaphragm. So you need to reconstruct then the diaphragm and the pericardium. She was admitted to the ICU after the operation just for 1 day and was then discharged 1 week after the operation. This was then followed like planned with adjuvant radiotherapy and IRMT with 54 gray. However, this case was not so lucky. 6 months after the completion of the trimodal treatment, we did a follow-up CT scan, and you can see all those lesions on her remaining lung, meaning that she had recurrence not only in the contralateral lung, but also in the chest wall and in the lymph nodes. We performed a biopsy, and this showed the recurrence of the known mesothelioma due to her pain in the chest wall. She then received local radiotherapy and also again chemotherapy. Sadly, this did not show any real effect, and she progressed after the chemotherapy with ascites and tumor growth into her lumbar spine, which actually led to a pathological fracture and needed to be decompressed surgically and stabilized, and unfortunately the patient died shortly after. Yeah, you may wonder why I chose this case, as a surgery is not really a not something to talk about. This is not a good case for surgery, obviously, but I think in this setting, those are the patients that we think about when we do the research. Patients 33 years old, we did everything we could for her, all the therapy available, still very sad outcome. Yeah, thank you very much.
We will start with Pelle Körberg from Varberg, Sweden, who will give a presentation from a patient's perspective. please.
Thank you. Are you ready with the sound over there? Okay, I'm grateful for being here today. I said before today, I thought I could call myself a cancer survivor, but a little bit, I'm not sure anymore. But 2.5 years ago, I wasn't that sure because I was not feeling very well. So I had got something that really bothers me because I get so much pain in my back. And so I went into the emergency all the time, and I will come back to that. But I guess during that time, 2.5 years ago, I was like this close to knocking on the heaven's door. So I really glad or proud to be standing here in front of you today. So I would like to express my sincere thanks to everyone working with these issues and working, the doctors, the nurses, the researchers, the scientists, and all others involved in trying to fight this thing, the cancer. So thank you very much. I can tell you, you are my hero. So thank you very much. I'm here to give you a short story, my short story of my period as when I had the disease, the cancer disease. So I hope you will enjoy it because it's my kind of story. So we heard today, you get the phone call you don't want to get. So it was a Monday morning, the first day after the summer vacation. I've been away with my family for five weeks. And my wife just left for work, and I was getting ready to get to the office, and the phone rang. 12 minutes past 8 in the morning. The weeks before, I've been in and out for the emergency because I got so much pain in the back, so I couldn't sleep. I tried to stand leaning to a wall and sleep during the nights. So I had so much problem, and I went in, I went out, more painkillers, and tried to, for a couple of hours, maybe I was okay. And then come back, and then so finally I said, I can't go home anymore. I need to be here. You need to take care of me. Let's see what this is. So I called my wife. I'm sorry, this is emotional. And I told her, they called from the hospital and I have cancer. And this is, I can hear her at the other side of the line and say, it's just got black. She told me afterwards that she said, you're dead. So it's so strong, the words mean so much, it's so strong to us that does not live with it every day, because this is a changing thing from one moment to another. It's hard to get involved in that feelings, in that emotional feelings that comes to us. So that's what's happening. The following 7 weeks were completely chaotic for me because they couldn't define what kind of tumor I had. So I was just I was hospitalized. I was actually hospitalized for the next 5 months. I was living at the hospital. So I couldn't, my body totally collapsed. That was because of the tumor. So I couldn't eat, I couldn't drink, I couldn't take any painkillers, I couldn't take anything. So I think I was in a kind of pain shock because nothing did work. So it's hard to communicate as a patient with everybody around you because they think you can eat. They say, oh man, just take this one, drink this one. But I can't get anything into my mouth because it was a kind of a trauma, I think. But I get the answer later because, of course, the tumor was aggressive, so it grew so much. So I finally had a kind of a handball in my stomach. So that's what's the problem, of course. But I went taking samples. I had a couple of samples. I didn't get out the materials enough to take the test to get to diagnose my kind of tumor. So the time just went on, weeks after week. I went worse. I was really thinking, my time has come. This is how I'm going to end my life. I lost in these 7 weeks. I lost 25 kilos. I didn't have enough food, so I think it's when you get a little bit distance, or it says, how could that happen? Because I got 875, what do I say, kolhydrater, carbohydrates, yeah, during 1 day. Now I'm a fully grown up man, so of course I will lose the weight. So I was in so bad shape at that time. So I called my wife, my kids came and said that I was ready to say goodbye to everyone. So at that time, I got a new doctor. He took really responsibility in me as a sick person. And he started to ask questions instead of just judging me as a patient. So we have a dialogue, we had a discussion, what I thought I needed, and I tried to help out. So I said, I need more food. And we did some operations so I could get the food from here instead of from here. I don't know the words of it, you know it. And I still had so much pain. And I thought there was a specialist that I met. It's a difficult word, I know, the ones that helps you with all this when you have the pains. Yes, that's a department at the hospital, aesthetic or something like that. Yeah. I met him once and said, I think that guy, he can help me with something. So they operated in a spine down here, all in my back, and pushed it out some medicational. So after that one, it's the same thing that the women gets when they try to have babies, or they're giving birth to babies. So I put that in my back, and after the first 24 hours was such a pain, so I almost jumped out of the window. That was the pain that I was facing. So I had one nurse at my room for the next 24 hours just to keep me not doing anything stupid. So that's kind of the feeling of the pain. But afterwards, they pushed it up a little bit every hour they could make it, and finally, I got no pain anymore. That was the first time I didn't focus on the pain. I could start to focus on the treatment or something else, because the pain was the thing that really kept me in my mind. So they got it. Back. I had an aggressive B-cell lymphoma, and it went on this 7 weeks from 3 centimeters when I found it to 13 centimeters in 7 weeks. So that's why my body didn't work. So the function just went out. At this moment, under these 7 weeks, of course, the family is the most important support. To have them coming to see, to visit you. Even though we had a discussion in the family, me and my wife, to try to make it as an ordinary days as possible for the kids and for my wife. My wife stayed at work. She thought that would help her, not thinking of me. So, and the kids, they went to school every day. They went for the sports activities. I mean, we got 3 kids with 3 activities each week and matches and all that stuff. So you can imagine the thing about the relatives, what the schedules becomes for them. So she was in kind of stress situation, I think, really hard to imagine. But they were fantastic. I mean, when we told our kids that I had cancer, they reacted so differently. The biggest, oldest guy up on the left, he started to cry. The middle one, the boy, he said, "You're gonna make it." So he was telling everyone in school or parents, friends of his parents that met at the training camps or whatever, and he said, "Father, he's going to make it. Dad's going to fix it." And the little one, she really didn't understand the differences. She said, yes, she has hoped everything's going to be like it was before. And I was quite frank and open with all my problem. I live in a quite small town. Everybody knows each other. Almost, at least, and I think it starts so many rumors in a small town. So I was a little bit afraid that people would tell such stories that to my kids, at least, your father is going to die and everything's going to happen. So I was open and transparent on what's happening. And I got a lot of support from other people. Sometimes some of the nearest friends is like someone who told me they get afraid of you. Oops, you got something. I won't be near to you. Maybe I get cancer as well. So it's a little bit. But I've decided very early that not judge people, their reaction, because that's personal as well. You can't judge people on their reaction because they are not used to this. So you have to stay, a little bit open-minded in it. But it was different. I got a friend in Stockholm. That was one of the biggest laughs during this. He was sending me a doll or a little figure from the Star Wars. And with the sign it says, "May the force be with you, Pelle." I think that was great. So sometimes in this little bit tough situation, a tough world, you need to laugh a little bit about it. You have to try to get back to the normal situation and have that kind of relation with your friends. I'm a team coach for the girl and her team, and for the middle guy and his team. And the club that I'm in put up we have a camera inside indoor where we play the floorball sport in Sweden. And when they finished every game, they went, these 15, 20 small girls went back to the camera and waved to me because they know that I was sitting there and watched the game on the laptop. So they gave back so much energy to really decide to, I'm going to make this thing. I'm going to really try to stand out. And so it's a lot of energy by, if you open up, you can also get back, I think. So that's my point of it. And finally, after these 7 weeks, the treatment can start. And I put this out on the Facebook and the Instagram as well, this picture. And I said, can you guess where for me it's a poison, right? I don't know what you call it, but can you guess what tap the poison is? So please answer, mail me the answer. I'll give you something. So it was a little bit to joke about it as well, but I needed that because when I was sitting there looking at this 3 times in that week, I said, oh, phew, that one is special, that one in that yellow tap, I think. I don't know if you see it. This is how I looked after a couple of weeks. You lose all your hair. And it's also one thing of this laugh I had, because when you wake up at the hospital, you go up, you do your morning toilet, and you take off the pants, and you see all the hair. It goes like this, there, everybody. There's nothing left. It's kind of strange. But you have to laugh about it. It's really funny. Every morning you have like some, okay. But, okay. during this time, I changed the department from the surgery department to hematology, and there was kind of difference in the way the doctors here came in every morning, had a pep talk. So I mean, it didn't happen at the surgery department. Sorry to say, but that's what's the difference. They really made me pep talk. So today, Pelle, we're going to think the best thoughts. We're going to make this a great day. Every morning, the doctors come in with that kind of energy. I mean, that was fantastic for me because I'm a former athlete as well. So that kind of language really did work on me. So I was pepped by that. So in the middle of this, there's a turning point. I think after you've done half of the treatments, you do this CT check to see if everything's going as they want to. And you can see the difference in what's happening because all the nurses, all the doctors, everybody wants to be with me because they say, this guy is going to make it. Because the treatment is really beating the cancer. So it was extraordinarily great in that point of view. So every morning, everybody came to me, everybody had to say, hi, how are you doing, Pelle, today? It's going to be a good day, blah, blah, blah. And so the whole department was focused on me, because I understand, because in the different, there was 2-3 others, they wouldn't make it. So they needed energy from us as well to continue their work every day. So it's a kind, you give and take energy to each other, I think. And one point, I'm a creative person, so at one night I started to make some drawings. I just wonder why they had so much beard, the drawings, but I think it was the loss of the hair thing. but I started to make drawings. I got some new energy. I was back in my normal life, being creative, doing something that I really understood again. So I made some of these, and I have about 30 of different with some funny speeches in them. So it was a nice way of just making something of the boring time spending on the nights at the hospital. And one last thing about that is that I was there so many months, and they still said, Pelle, you need to go home. You're hospitalized. It's not okay. You need to go home. You have to stay home instead and come here for the treatment. I said, no fucking way, because you're going to, my wife is going to crash. If I go home, and she's going to be a nurse on me every night when I vomit, because I vomit about 16 times during one day after the treatment. So you don't want to keep your wife awake because she had 3 children to take care of, and me. So I said, no, I'm not ready to go home. And we had a fight, me and the doctors, about that. And I said, you need to go home. Now I go home when I'm ready, I said. So I really, at that time, I was a little bit strong again in my mind and know what's good for me, what's good for our family. So I really think I saved the family life after that discussion. This is my way back. It's the first time I'm outside the hospital, and I'm outside the home where I live, and it was cold. It's cold when you don't have any hair, I can tell you. Actually, the first thing you notice how cold everything is, though. But it's a long way back. A couple of months later, I do my first day at the job again, at my work. So, but I think it's fantastic, though. So my final picture is, it affects us all. I don't know if you see the picture there, but this is the 1st of March this year. I had the last meeting with my doctor, and he said, okay, you're fine. This is going to be fine for you. So you're ready. I check you out. This is my son coming home from the world trip. His first one. He's been to Australia. He's been to Cambodia, Thailand, or wherever. And he comes back with a tattoo on his underarm. I don't know if you can read it, but it says fat cancer. So what I was trying to say with this last picture is that this one is it affects us all. He was so proud of that one when he came home, and I was a little bit like, tattoos is not really my thing, but he was so proud of it. So it affects us all, I think, more than we can imagine. So thank you for time. Thank you for listening.